Hello, I'm Dr. Yolanda Singh. This is a video for NAC OSCE preparation, and the topic is Pediatric Respiratory Distress Counseling. Disclaimer: the content of this video has been made for educational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now, the general approach for counseling cases, the cases are usually 11 minutes total, and after which there are no questions by the examiners. The exam scenario is given at the door, and there's 2 minutes to read the scenario and make notes before entering the room. Now, a good tip to remember here is to utilize your 2 minutes to formulate differential diagnoses and think of pertinent questions to ask in the history. At the sound of the bell, you'll knock on the door and enter the room, introduce yourself to the parent, sanitize your hands, and proceed to develop rapport with the parent. The counseling cases usually involve a focused or brief history, and for the pediatric respiratory history, you'd want to think of a few possible causes or conditions that this patient may have. Common presentations in children include infectious diseases such as pneumonia, bronchiolitis, croup, epiglottitis, and pertussis. It can also be airway obstruction due to foreign body, asthma or a tumor, or congestive heart failure, or anaphylaxis due to food allergy or insect bites. The first step in the history would be to analyze the chief complaint. Things such as the onset. When did the illness begin? Was it sudden or gradual? Then you'd want to look at the character of what's been happening with the illness or symptom. For respiratory diseases, is there a cough? And if so, is it productive? If it is, you'd want to know about the color, the quantity, is there any blood, and has there been any odor? Is there any specific sound to the cough? For example, clearing the throat could indicate gastroesophageal reflux or a postnasal drip. A barking cough could indicate croup. Whooping type of cough could be pertussis, and a hacking type of cough, pharyngitis or pneumonia. Next, you'd want to look at associated events. Are there any associated sounds with the respiratory distress? Musical sounds, which may mean wheezing, noisy breathing, which may mean stridor. Is there any shortness of breath or difficulty feeding? And has there been any color change, which could indicate cyanosis? It's good to also check on the red flags for respiratory diseases, such as a runny nose, earache, pulling or tugging. Is there any discharge from the ears? Sore throat, swelling of the lips and face? Perhaps there's a rash. Also, has there been any change in the child's mental status, such as them becoming sleepy, irritable? Do they have any abnormal positioning, such as tripoding, which can be seen in asthmatic crises? And is there any constitutional symptom? Fever, night sweats, weight loss, anorexia, lumps and bumps, which could indicate lymphadenopathy. Then you'd want to know about the duration of the illness or symptom, how long each episode lasts, was it sudden or gradual, is it seasonal, is it getting better or worse? And then it's good to inquire about aggravating and relieving factors, and was any treatment given, either in the past or for this current episode. Given that it's a pediatric history, you'd also want to inquire about the child's past medical history, illnesses, hospitalizations, and for the young children, you'd want to look into birth history, immunization, nutrition, developmental history, and their environment. And this is a good point to screen for risk factors for child abuse and neglect. In the older children, Inquiring about school performance, substance use, and sexual activity is also permanent. Then finally, family history and known allergies. The focus history is usually brief and usually targeted at your possible differential diagnosis that you came up with based on the scenario that was given to you. Now, this is a sample case. A 4-year-old girl is under observation in the ER after experiencing anaphylactic reaction to peanut butter. Take a focused history and counsel the mother on peanut allergy. The steps to take. As we discussed before, knock on the door, introduce yourself, sanitize your hands, and determine how the parent wishes to be addressed. Then you'll proceed to taking your focused history in order to establish how the child is doing now since being in hospital, and ensure that you empathize with the parent. And you'd want to determine the events that led to hospitalization. Inquire from the parent what they know so far about the diagnosis and how much they would like to know. And allow the parent to ask questions. Then you can begin your counseling. For this particular case, it's a known peanut allergy. So you state the diagnosis to the parent and give a few details that's specific to nut allergy, such as it being a lifelong condition, it's relatively common in children, and it can be life-threatening. For counseling, you'd want to counsel on the cause so that the parent is aware, which is peanut exposure, and then proceed to strategies to avoid this particular allergen. These include checking food labels for peanut, avoiding high-risk situations such as buffets, ice cream parlors, and eating unlabeled food. Avoid other 3 nuts as well, because cross-reactivity is common. Advise the parent that symptoms may develop within minutes to hours. Describe some early symptoms to look out for, which would be itching and tingling of the mouth and throat, unable to breathe, swelling of the lips and tongue, hives, being flushed, and experiencing abdominal pain, nausea, and vomiting. You want to advise the parent on additional educational resources and also on what emergency responses or steps to take should another reaction occur. In this particular case, it would be to always have an EpiPen available, such as in the child's bag, leaving it with the school nurse, and also in the car, and also teaching the parent how to use the EpiPen. It would be good to also advise the parent to inform the child's school about avoidance of nuts and providing them with a written emergency plan. You'd use the opportunity at this point to check in with the parent that they understand all that you've discussed and ensure they have an appropriate prescription for the EpiPen before leaving. So in summary, regardless of the diagnosis, the key to counseling for any condition, whether it be respiratory or another condition, it would be learning the red flags of that particular condition, ensuring that you empathize with the patient, know the particular triggers of that condition, how to avoid the triggers, what appropriate treatment or medication is available, what the appropriate emergency response and services are, know when to refer to a specialist, allow room for questions to be asked, and offering additional educational resources. Lastly, ensuring that follow-up is arranged for this patient. I hope this has helped you to get an overview of counseling for respiratory pediatric cases. Thank you.